Hi everyone, so we're going to get started now. So thanks everyone for joining us today and welcome to the Provincial Human Services and Justice Coordinating Committee webinar on Crossroads and Mental Health Crisis and Law Enforcement. My name is Tasha Rennie and I work for the HSJCC Secretariat. I provide communications and member engagement support to the network. So for anyone who is just calling in right now, if you are calling in using the teleconference line, could you please just make sure that your phone is on mute? So you won't automatically muted. So if you could just do that yourself, that would be great. Otherwise, it creates some feedback and we can hear the background noise. So once again, just everyone please make sure you're on mute. Okay, let's get started. So before we get started, I just wanted to go over a couple of housekeeping items about our presentation today. So we will have some time for questions. We'll have about 10 minutes at the end of the presentation. If you have any questions, feel free to type them into the chat box. You can type them throughout the presentation, and we'll get to them as many as we can at the end. As well, if you are having any sound issues, just feel free to type any questions you have about that into the chat box as well. The webinar will be recorded, and we'll be sending out a link to the recording as well as the presentation slides to all of our participants, and of course we'll make it available on the HSJCC website. We'll also be sending out a link to a brief evaluation survey, and we'll just ask that everyone fills that out just to help us better plan our webinars in the future. So that will all be going out probably within 24 hours or so. And for anyone who's joining us for the first time today, the Human Services and Justice Coordinating Committee Network is made up of over 39 local committees, 14 regional committees, and 1 provincial table. So we currently have around 1,600 members across the province. Each HSJCC is a voluntary collaboration between health and social service organizations, community mental health and addictions organizations, and partners from the justice sector. Okay, so our presenter today, we're very pleased to have Staff Sergeant Jason McElveen of the York Regional Police. And with that, I'll pass that over to you.
Thank you, Tasha. I feel like I'm doing a bit of a radio broadcast today, so hopefully I don't slip into a radio voice and come across as kind of a cheesy top 40 DJ, but I will do my best. Thank you for having me. Just to start, the title of this is Crossroads, but it really should be more of a merge point, I think. And I didn't think of that till after I submitted this, because we're not really dealing with an intersection here where things collide. This is more of 2 paths where public health and law enforcement merge in the same direction in an orderly fashion and work towards a collaborative common goal. So I'm with York Regional Police, and just for those that don't know about York Region, I'll give you a quick snapshot. About 1.1 million residents, about 7% increase every year in population. Seniors are the fastest growing segment of the population at present. We have 3 to 4 hospitals and a huge geographic area. Just a map, I'm hoping you can all see the map. It's a rural-urban dichotomy in York Region, heavily urbanized, high-density housing in the south end. We go down to Steeles Avenue, so we border Toronto. We head all the way to Lake Simcoe, and our east-west boundaries are Durham and Peel Region. So there's a lot of, there's a difference in policing between, I would say, urban and rural. But at the end of the day, everyone's problems are the same, no matter how much money you have or lack of money you have. I've been an officer for over 22 years. It's all the same. I see the same problems. It doesn't matter what background you're from. Everyone suffers from the same problems. Very diverse population in York Region, and that presents both challenges and opportunities for law enforcement and public health. Between 2006 and 2016, more than 51,000 newcomers came to York Region. When you ask people if they consider themselves an immigrant to York Region, it actually spikes to just over 450,000 people that identify themselves as immigrants to York Region. So we're talking about second-generation Canadians and below that. So I think it's 47% of our population. There are over 200 distinct ethnic origins in our region, and we have worked very hard as a police service to partner to get ourselves involved in the newcomer strategy. And I'll talk about that a little bit later in the presentation. A bit about what I supervise. Under my direct command, I have a mental health support unit that includes 4 full-time officers and 1 sergeant, a senior safety unit, and there's 2 full-time officers associated to that unit. I have 2 full-time social workers. They're not officers, despite what my PowerPoint says. They're actually social workers. I have an auxiliary unit of up to 160 members, a crime prevention unit of 5 officers, crime stoppers unit of 2 officers, and a volunteers unit, including 2 civilian members and 500 volunteers. I only say that because when I come into work each day, I don't know what's going to hit me, and I really rely on my Sergeant Chris Palmer to run the operational side of the mental health team. He does a wonderful job, and I'm not sure if he's listening or not, but if it wasn't for Sergeant Palmer, I don't think we would where we would be at as a police service when it comes to mental health services. A little statistics on York Region, and I'll update these in the next couple of slides. We just finished our 2019 business reports. In 2018, we answered just over 5,000 person in crisis calls, attempted suicide calls. We're looking at a 16% increase year over year based on those statistics. That did not count, or that count did not include other call types. And what I mean by that is we as a police service may go to what we call a family domestic, which has its roots in a mental health issue amongst the family. And when we use our RMS system, which reports how an officer makes a report onto the system, there was no space or no flag that an officer could indicate that there was a mental health concern involved in this call. So we all knew the number was much higher than that. So myself and Sergeant Palmer put in place a system in our RMS system to start more, I guess, have a better number in terms of what accurately is involved in terms of a mental health call. And you'll see in the next couple of slides how that number grew when we put that into place. I'm seeing that, will these slides be shared afterwards? Yes, they will. So thank you, Jennifer. I'll make sure that they are shared. Our MHST unit, which is our mental health support team, will approximately answer 120 live calls a month. And that's a crisis worker and a police officer going to calls when they can in terms of assisting frontline officers. Again, I talked about seniors being the huge growth rate in seniors, and that's going to affect us drastically as we move forward in terms of how we deal with seniors' concerns. I'm talking about dementia and Alzheimer's and people that go missing. I'm not seeing a question about stats on number of missing persons. That isn't my, we have stats on missing persons, just not my particular area of expertise, but those would be recorded sort of as a sort of a transparent report. So you can always email me after and I can find that out for you, Maureen. So when we introduced a new auditing system as to how to measure, more accurately measure mental health calls, we discovered that instead of having that 5,000, we were up to almost 7,500 calls in terms of reported calls where an officer went and made an actual report. And even this number is misleading because our officers are still going to a lot of what we say that maybe a dispute call, where we call they notebook the call, where there's no report generated. And so even though that dispute may be based on a mental health issue between neighbors, we're still not getting that. So we're still working to fine-tune that to get the most complete number, but that is a work in progress. And I think you can see almost the 5,000 increase in calls, 5,000 calls. That's incredible over 5 years, and that number is only going to go up as the population grows. Okay. Again, some more data, and this is where we really found out that we were missing a lot of the data on the actual number. We looked for calls for service in 2019. We had just over close to 1,800 suicide calls in New York region. We had emotionally disturbed calls at 3,365. So when you put the numbers together, we're looking at close to we're missing about 2,500 calls when we got that final number of just under 7,500. So it really does pay dividends for services to put in place audit systems to really make sure they are in fact capturing all that data, because it is relevant, especially when you have to go before a police services board or one of your community partners in an audit and justify the reason why they are paying for crisis workers to be part of your mental health support team. So those numbers didn't shock us. We always knew they were a lot larger than they were, but now we have more accurate data. And I think the Police Service Board and our chief understand the fact that the front line has become, I would say, almost the final repository for people calling now, because they have nowhere else to call. And so we as a police service often get called into the call because there's just nowhere else to turn to, and that inflates our numbers. So the goals of our mental health unit, which is the crisis worker and police officer model, and I do realize there are lots of different variations across the province on how people deliver mobile crisis response. Their main goal is to conduct an assessment of the person's mental health status and really assess the risk to harm to themselves or others. Provide attending police officers with guidance and expertise in establishing apprehension criteria or resolution and de-escalation strategies. Assist in developing crisis management plans. Provide resources and supports for the person and or their families. And we see this all the time, especially with seniors, where an elderly caregiver has a wife or a husband or that suffers from dementia, and they're trying to navigate the system for help, and they really have a very difficult time. So whether it's our social workers or our senior safety officers, they will assist in navigating and getting them the right person, because that's key. And we have a great success rate in that. We facilitate subsequent follow-ups if required with community resources. We assist at hospitals if an apprehension is made, so our crisis worker and our officer can attend at a hospital, take over an apprehension, relieve the officers, and stay there until such time as the crisis worker at the hospital can liaise with them to make an assessment if we are indeed going to apprehend, or at least a form is going to be issued by the hospital. But again, the main idea here is to keep officers out of the emergency rooms and prevent those future repeat calls by doing all of what I just spoke about. I'm going to speak now a little bit about the internal dynamics of our mental health support team. Again, this is a partnership between York Support Services Network. The team consists of an officer and a crisis worker. As I said before, we have 4 full-time officers that are associated to us. However, we have up to 18 alternates that will come in due to training, health needs, or whatever. So we do have a fairly big unit. It's worth noting when there seems to be a lot of genuine interest amongst our frontline officers when we post a position like this. There is really a lot of genuine interest in being part of the team, and we don't take a person unless they have that sincere desire to actually to be involved. And a lot of our members that are on the either on full time or on their alternates have personal experience in dealing with mental health or seniors issues. So they bring that passion to the front line, and it's appreciated by a number of officers. Again, our team consists of a crisis worker and a police officer. And again, I know there's lots of different variations on how that works across the province, and that's fine. We're not saying we're the best. I think that seems to work well in York Region. We divide our teams up into south and north. That way, the the rural south has a dedicated team, and the rural north has a dedicated team, and the urban south has a dedicated team. Not to say that they can't cross over, because they certainly do, but we noticed that we have a large number of nursing homes sort of in the Newmarket area, and we have a lot of calls to these nursing homes to help with help mitigate and help. You turn your sound up a little, please. Okay, sorry I missed that. So just going to turn the sound up here just a little bit. Yeah, hopefully that helps a little bit. Anyways, we operate 2 teams, and they basically operate on 12-hour shifts, 4 days a week, and then they're relieved by the other teams. And again, we offer services from 10 a.m. to midnight. When we drill down on the analytics, that seems to be the most efficient time to have these units out there. And not to say we don't see anyone after midnight or before 10 a.m. in the morning, but again, we try to double up where we can over that coverage period where we have our peak volume of calls. Our social workers are the backbone of the unit. They're internal YRP employees, which means we hire these people. They're not contracted out. They actually work for us. They're paid by us. They get trained by us. And that really pays a lot of dividends because they feel part of the team, and they are included in all our discussions in terms of how we develop programs and policies and procedures. Their knowledge is invaluable in helping us sort of mold our program to the needs of our community. They're the ones that keep a critical eye on occurrences. They ensure that persons in crisis and vulnerable persons have and are connected to what they require in the community to function. They're the ones that are outreaching to the families to make sure that after a call has occurred, they are in fact in touch with the people they need to be in touch with. That type of feedback is invaluable for us in terms of being able to present. They're not case managers, but they will speak to the case managers to present sort of any kind of thing that we might miss as a police service. We're not social workers; we are police officers. They speak the language, and again, before they keep us. They really do a very good job in just getting the person in crisis or the family of a person in crisis to the resources that they need to speak to. They actually review all our person in crisis reports, and this may again include neighbor disputes, domestics, habitual trespassers, vulnerable persons, homeless people. So they are out there actually, much like a supervisor, reviewing these reports to make sure that we are covering off all our bases. And if there's something that we've missed as an organization, they will either bring it to myself or Sergeant Palmer's attention, and we can rectify that. And they act as an internal resource to officers on programs and resources in the community. So our officers are, again, out there, at the calls. And generally through the daytime, they do get a lot of calls from officers that are at calls where MHST cannot make that call, and they assist the officer in sort of, either developing their grounds for apprehension or just, putting their observations into sort of a clinical terms where if they are going to apprehend, they know when they go to the hospital that, this is what they should be focusing on when they liaise with a crisis worker. I see a few questions have popped up, so I'll just, Dina Fami, looks like, do all regional police have the same support for mental health? I work in Scarborough, and I wonder if looks like we would provide the same support. So no, we don't. All police services are different. We've, as a police service, made a significant investment in mental health, everything from.
Sorry to interrupt. Just a reminder for anyone who's calling in using the teleconference line, we're not able to mute you from our end, so if you could just make sure you're muted yourself. That's why we're hearing a bit of background noise. So thanks, everyone. Sorry about that.
Okay, yeah. So again, not everyone is, the same, and it's a function of everything from, you may have different partnerships. There may be a different budget. I can't speak for other police services, unfortunately, but all I know is that I think we have a pretty good plan in place and a program in place to deal with our community partners and our persons that suffer from mental health issues. Looks like Vanessa Rankin, do you believe 2 social workers on the team is insufficient for demand? I would love to have more social workers, yes, but again, it's a function of budget, and I said before, we get if we need to bring in someone else to review cases. I have a sergeant there, and I have a mental health support team that can also assist. So I would love more, but I don't get everything I want. We all live in a budget constraint period, especially with police services. So unfortunately, well, I'd like it. I'll continue to push for it, but no guarantees. Anyways, I'm just going to go through to the next slide here, and I'll do my best to answer questions. If I miss one or two, you can always come back at the end and ask. Essentially, they also, again, I talked about the follow-up with the person in crisis and the family to ensure that community supports are in place. We do that because we don't want, to have those repeat customers. And everyone has them. They go through the system, and some people, some hospitals in your region have actually, physically barred people from coming in because they're there all the time. And at the end of the day, we get stuck with them. So, it's going to be, we've got nothing to solve that issue of that habitual sort of person that's always calling police, whether, they believe people are coming through their walls, or the hospital's out to kill them, or the police are out to get them. We do our best, but again, we are a police service, and unfortunately, just because of the times that we live in and the constraints that have happened over the past few years, we've become the final repository for a number of these individuals, and we try to be as compassionate as we can as a police service. But at some time, we just have to, do the best we can. Is what I'm saying with what we have. And sometimes, is it the best approach? No, but that's the world we live in right now. So we try to train our officers to deal with these situations on a one-by-one basis and offer them and the family as much as we can offer them. So why do officers call us? Well, we can keep people out of the ERs. We can save time on your call. When our MHST team is engaged, or a crisis or a social worker is engaged in the call, our actual apprehension rate falls from 56% to about 19%. That is a significant time saving for the organization. It's also a significant money saving, element of our organization. Right, I don't have an exact formula, and I'll go into this a bit later, but you figure that most frontline officers, they're going to be 2 attending one of these calls. If an apprehension does take place, they could be at a hospital up to 3 hours, waiting for an assessment team to come and speak with them. And most frontline officers make around somewhere between, in the province, between $50 and $60 an hour. And that's kind of the baseline element in terms of how you determine how much a cost like a call like this actually costs. And something, a lot of these calls may involve a patrol sergeant. They may involve the MHST, and so that figure alone is challenging for a police service, and it does put a final cost, albeit a low estimate. And it does give the police service board the amount of resources we are pumping into this problem on a year-to-year basis, and it is significant. I'm going to show you a couple of slides now, and some of you may have seen these before, and this is sort of a common thing across the province. When you go to a hospital, you'll see lines of police cars that are lined up, either outside the emergency department or, in this case, on the shoulder of the road going to the hospital. And again, this just demonstrates, these are officers that have more than likely had to bring someone in under a mental health apprehension, and they're going to be waiting around the hospital probably for a significant amount of time. And it's, when you see 8, 9 cars at a hospital, you're going to probably be waiting significant periods longer than 90 minutes, which is kind of what we average out on. So that alone is should be a red flag that we had to be doing business a better way because we're making that investment on the front end to send all these officers with apprehended persons to the hospital. There's got to be a better way to do it. So, and I'm not trying to sell any product here. I don't work for Health IM, but I will spot good because that's the product that we've invested in. So everyone probably on the line has heard of a mental health screener, right? Screeners have been around for a very long time. Basically it's just a way for when an officer attends a hospital to give information to hospital staff, the ER staff, to augment or at least, give their grounds for apprehension other than just, he wanted to kill himself and that's why we brought him in. So great idea. It does give the hospital more information. Oftentimes when we do bring an apprehended person to a hospital, they've actually gone through a de-escalation period in the car and they've calmed down. So what the officers observed at the scene now has de-escalated to a point where the person is no longer in crisis. But that could be 2 or 3 hours later. So crisis workers kind of just, sorry, my voice is cutting. I apologize. I'm just getting over a cold. So anyways, I'll try and speak up for you. Anyways, again, it's that time frame is, we've got to cut down on that time frame, and we've got to be able to get hospitals sort of better information so they can make a more informed choice as to whether or not they're going to form a party or not. And if we could provide sort of an electronic screener which does capture the officer's observations, but in clinical terms, we thought that would be a really good investment because we'd be giving the hospital the information they need in a language that they understood. So under Health IM, we did a contract with them, and now we have a digitized electronic screener for our officers to use when they encounter any person with a mental health problem. So every time a member of YRP comes into contact with a person in crisis or anyone that has a mental health or addiction issue, we will fill a screener out. That screener will be used to provide a history of police encounters. So we will be able to understand whether the person is actually in an escalated state or he's at his baseline behavior. It isn't meant to replace officers' observations or tell them whether or not they should apprehend. It's meant to enhance an officer's observations and then take those observations and put them in clinical terminology so the staff of the hospital can understand what they saw when they encountered this person 90 minutes ago, 2 hours ago, and so on. I should also mention that the current HSJCC framework, which was announced probably, I think it was in June 3rd, 2019, did call for services to adopt some form of mental health screener across the province. And I don't want to sort of steal the OPP's thunder, but Lisa Longworth and Julie from the OPP, who I work with almost on a month-to-month basis now, really have done a fantastic job in developing their own screeners and stuff. So I'll talk about that a bit later, but I'll go on. So I don't want to, again, get too far ahead of myself here. Oh, and Paul McDonald has also just pointed out that so the actual screener time is only 5 minutes. So basically when an officer makes an apprehension, and if the person is calm in the back seat of the cruiser and there's no security or imminent threat to an officer, the officer, before he actually goes to the hospital, can fill out that screener in less than 5 minutes, and then they transmit that through sort of an electronic, I guess it's almost like a cloud where it goes from the police cruiser to the hospital, and it prints off a report. In the case where we have maybe a violent situation where we have an active person that is escalating and not de-escalating, an officer can just hit an en route button to the hospital, and that sends off a little alarm to the hospital, and that person actually, when the time we get there, hospital staff are usually waiting for us, so we can get that person into a secure environment where they won't harm themselves or anyone else. So yeah, it really doesn't, it doesn't take a lot of time for the officer to complete the screener. And what it kicks out at the back end is really amazing. So I said before, just in terms of the dilemma in terms of how much this costs. So when we did our budget presentation in 2018, our officer wait times at hospitals was around 7,200 hours. That translated into just about $460,000 annually of officers just waiting at hospitals. That didn't include the pre-time or the after time doing the report. That was just hospital wait times. That's a significant number for police services, whether you're a medium service or a large service. I imagine the larger services like Toronto and Ottawa, probably those numbers are a lot higher. You know, when we look at our return on investment for this product, that number played a huge part in our deputy looking and actually providing the money for this software product. So the health, so this is what you're looking at now is sort of the traditional screener, where this would be sort of on a clipboard in a cruiser, and once they made an apprehension and got to the hospital, and they were waiting for the crisis worker or a nurse to see them, they would fill a very short one-page screener or a two-page screener, just depending on what the service would be. And basically, you're just hand-bombing it in the emergency room while you're waiting. And again, if that works for a police service, so be it. You know, we have made a significant upgrade and investment in the Health IM software, where we're looking at an electronic report which looks like this. And I didn't have time to put all the screens in. However, I just wanted to show you a few screens on how easy. So it just tubes some information that would go into the actual screener. We would put these in, and again, it's just tubes some information. And then there's a bunch of screens there that would also note their observations. And so let's say we're talking about hallucinations. Was this person experiencing auditory hallucinations? Well, if an officer didn't know what an auditory hallucination was, he could hold his arrow over the cursor, and it would actually explain what a hallucination is. And that way, he would click on the report. Yes, he was experiencing auditory hallucinations. So that is gold when we go to the hospital, because again, most of our officers, when they went to the hospital, when they asked, well, why did you apprehend the guy? Well, he wanted to kill himself, and that would be the extent of it, right? And that didn't help anyone. So we're finding that dynamic at the hospital between our officers and the staff there, the emergency room staff, has improved greatly because we're giving them the information that they need to make an informed decision. And I said before, now that we started giving this to the hospital, it was a bit, I'm not going to say that it wasn't a rocky start with some of our hospitals in terms of they were maybe a little bit skeptical of this software, but our officers now are actually speaking the language. So this software has trained our officers really well to the point where they don't even have to show the report. They can actually just have a one-to-one conversation with a nurse member to say, or a crisis worker to say, hey, you know, he suffered from this, and he lists the ailments in clinical terminology. And the hospital loves it, the doctors love it, and it gets augmented by this report that comes out. So the other thing that is also really what we asked Health IM to do for us was provide de-escalation advice for officers prior to they got to the call. So in our report, well, en route to the call, our call takers and our dispatchers will look at the actual any kind of previous contact that we had where we used the screener. So let's say person X is in crisis today, but last time the police encountered this person, the officer noted that his cell phone was visible in his vest pocket. And by removing that cell phone from his pocket to his cargo pant, he was able to de-escalate a situation rather quickly. So now the officers going into the call do have that opportunity to read that advice. And we've gotten several emails now to say, that was amazing advice, because when I got there, had I not known that, I would have had to probably spend several minutes trying to de-escalate someone, and who knows how it's going to go. So that de-escalation advice is relied now on our frontline officers for a number of different encounters, and they find it very, very beneficial. So I know that I see a whole bunch of questions stacking up, and I'm running out of time. So I'm going to try to get through this first, and then I will leave some time for questions, I promise. The other thing about Health IAM software for us, myself and Sergeant Palmer really spend a lot of time on the analytics portion of the software, and that analytics portion, as a police supervisor, tells us a lot of things. And one of the things that I'll cut this down a little bit, but one of the things we've noticed is that some of our officers have a tendency to apprehend way too quickly and way too much. This software compares officer apprehension rates on platoons, officer to officer. So let's say B platoon has a platoon average of 75%, which is much higher of apprehension rate. So we would be able to drill down and see, okay, well, there are 2 officers on B platoon that apprehend 100% of the time every time they encounter someone. That to us represents a training issue, and bringing someone in, speak to those officers, say, hey, guys, I think, I know you have liability concerns here, but I mean, we can tell by the numbers, I think you're too quick. You're not asking those probing questions, and this software does allow for that. So, yeah, as a supervisor, we really find it really sort of accurate as to, who may be apprehending way too much. So, anyways, I digress from that, and I will move forward. Again, the goals of the mental health screener are to decrease our apprehension rate to about 40%, decrease hospital wait times to about 75 minutes, and again, improve that risk management. So I will go on to the second part of this, which is collaborations. And this is the obligatory cop joke here. There's a donut and a cup of coffee, and the donut saying we're going to look forward to our working relationship, basically. So I only include that because this is a police presentation, and I know there's police officers that might appreciate that. So moving forward, collaborations, situation tables. I think most services now across the province have situation tables. Basically, we call ours the rapid response table. We work on the premise or the threshold of acutely elevated risk, that when a person actually hits that acutely elevated risk, that allows police services and its collaborative partners to share information, health information about that person, and have a plan moving forward on how we're going to at least have that wraparound service delivery to address the issues in this particular individual's life at this point. I don't know about other police services, but we seem to present the majority of cases to the situation table. All but one of our presentations have met the threshold. And once the wraparound service concept engages, we are really noticing a huge success rate of these people not returning to the rapid response table and not being on our radar anymore. So I'm a strong proponent of these, and I really believe that they have value, not only for persons in crisis, but for the family that also suffer. And again, we're looking at about 75% success rate in terms of people not having that repeat contact. So those kind of numbers are very good. All right. Welcome centers. Again, I mentioned earlier on about the York population and 47% being considered themselves to be immigrants to Canada. Again, this does present challenges to police services when it comes to mental health. We have noticed that a lot of newcomers to Canada will not contact police until a person may be in crisis, or they won't engage with any type of resources. It may be a taboo, maybe they just don't know. But by the time that person does get into crisis, the chances for any kind of long-term behavioral success, as everyone knows, begin to decrease, right? So we've actually used our MHST teams to go to our newcomer centers and speak to new immigrants about stigma, about what the police do, about what crisis workers do, and how we can help them. And the actual response that we've got from this has been phenomenal. So we have 5 welcome centers in York region, but that may not seem like a lot, but what happens is, because these people will go back to their particular, either their faith-based institutions or their community centers. And then we get calls from mosques. We get called from, other community groups, schools, to talk more about this, to get the messaging out there. So that has provided a greater network into our newcomer base. And we find that, it's too early. We just started this initiative last year, but we can already see the dividends in terms of that community engagement, which is my mandate under my unit. So they have done a wonderful job. Mental health hubs, I'm not sure how many people have mental health hubs in their particular community that are listening right now. We are in the process of having our hub, basically the blueprints for it are done, site selection is done, and we're just waiting on a final word from the ministry in terms of, when we can start. All our community partners have come together to back this idea of this wraparound service delivery concept, and having this in a location which will service all of York Region. York's a huge region, so it was really central and really pivotal to us to find a central location which everyone in the region could actually attend when needed. The only issue that we've had in terms of the logistics of all this is this going to be a Schedule 1 facility or a Schedule 2 facility under the Mental Health Act? This is sort of an ongoing battle, not battle, but a conversation that we've been having with the Ministry of Health. My personal belief is that our particular hub will fit into the Schedule 2 stream under the Mental Health Act, and it becomes a question is where can I legally take a person or an apprehended person for service? So, I don't know how big an issue that is. I don't know, but I'm just reading what the Mental Health Act says, and there seems to be a little bit of, the need for greater clarity when it comes to the Mental Health Act as to where can we lawfully take a person. We're acting in good faith, but the legislation is pretty clear. A Schedule 1 facility seems to be where we can take them, and I know a lot of police services across the province are taking, us included, to Schedule 2 facilities. Is it lawful? No. Is it quicker? Yes. Is the person getting a better service? Yes. At the end of the day, it's about this person that needs help, right? And if we can get them to a place where they're going to get help quicker and they're going to get to the right people in a faster environment, then we'll do what we can. I'll talk briefly about community safety plans. I'm involved in the York Region one. We have a meeting actually on Friday. We're bringing in our area partners to meet with them. We are, this is just another opportunity for people to engage partnerships, to look at where, the best way I can put it for us is, it's a great opportunity for people to do an inventory of existing programs and services. See where you may have overcapacity in some areas and undercapacity in other areas. And is there an opportunity to realign those resources to areas where you have undercapacity? And one of the areas that I think the ministry has hinted at all along is essentially youth services are needed. And so if you can work with your municipalities to, I'd say take away, but at least realign where you've got that overcapacity into into youth services, that's what you're looking for. I mean, that's where you're going to see the most efficient use of resources. I don't have to tell a lot of people here that if you can address a problem at a younger stage in a person's life, the better chance for long-term behavioral success you're going to have. By the time you get to teenagers, into young adulthood, into adulthood, you're going to be treating that problem probably through medication and ongoing crisis or clinical services. That's very expensive. So I think what the province is suggesting is that let's just try to put more money into youth services and see if we can really have behavioral change at an earlier age. So I know that's what we've been focusing on. One thing that we've been really working towards is putting crisis workers in our 911 center. So we have a warm transfer when we have a person that we don't have a sort of an exigent circumstance where we have imminent danger to someone. We have a lot of parents that call in to police and they're having a problem disciplining their child. Not a police call, but if they do call 911, we have to go. We are trying to work with some of our obviously our communication center and our area partners to embed a crisis worker to do a warm transfer on these calls to someone that could better serve them, whether through out services or through having a crisis worker attend the call. So that's an ongoing battle. We've been sort of back and forth right now. So hopefully by the end of this year, me and Chris Sergeant Palmer are pretty gung-ho in getting this done. So hopefully we can have this done soon. But again, there's no guarantees, and it's a work in progress. And then finally, I'm just going to end on this because I think I'm running out of time. Two things. I will point out that under the current HSHEC framework, they are looking towards for all police services to enter into transfer of care agreements with their hospitals. This has put an onus on police services to work with hospitals so they can have sort of a more efficient transfer of a person from the law enforcement side to the health side. All I'm going to say on this is two things, is that the OPP has a model agreement. Julie and Lisa from the OPP have worked hard on this, and we are going to use their agreement to send to our hospitals. The problem that we have is that many different police services have, they may use the same hospital. Like for us up in Newmarket, Simcoe, Barrie, York, OPP, and even Durham have used our hospitals. So that would be 5 separate transfer of care agreements that a hospital have to enter into. We believe that there is strength and merit in having a standardized approach with a little bit of flexibility built in, where we wouldn't burden the hospital with 5 different transfer of care agreements which said 5 different things. So, I do have a committee. I call it my GTA Mental Health Working Group. We just started. We had our first meeting in October. I'm going to ask Lisa and Julie to come in at the next meeting and speak to their transfer of care agreement. And when we do that, I will leave my information. If anyone in the GTA that wants to join that, please contact me. 998@yrp.ca, and I'll certainly get you in. So, again, I'll just end by saying that I called this Crossroads, where mental health comes into contact with public health. And again, it's more of a merger. We're all going in the same direction. And I think it's time through the collaborative process that we work together as opposed to working in silos. So I have about 10 minutes or 8 minutes to go, so we'll take some questions. So let me just...
Yeah, thank you so much. That was wonderful. So I see that a lot of questions and comments have been coming in throughout the conversation, throughout the presentation, and there's been some conversation happening with our participants. So we'll just invite anyone, if you have questions that haven't been addressed already, questions for the presenter, please type them in now, and we'll try to get to as many as we can. And then, of course, you've made your information available for anyone else who would like to reach out to you.
And I will point out, that's my new puppy, by the way. That's Maddie, and I had to get her into this somehow. So that's her just after she destroyed her reindeer, which you can see in the back corner there, which has been torn apart. Baby shark with her sharp teeth. Anyway, sorry, I digress. So on these mental health teams, are the officers wearing plain clothes or uniform? Our officers are in plain clothes. Again, sometimes, essentially, we made that decision to be separate and not try to escalate a situation by the presence of a uniform. We find that having a uniform present has, in fact, escalated situations, so we made a conscious decision for officers to be in plain clothes. Does having the social worker as an employee help with privacy issues and the sharing of information? Yes, it does. Again, they work together in tandem in the car, and as they approach these calls, the officer, he's more than just a protective body. They actually engage in the calls as well, and they work together as a team. I know sometimes there is just this idea that the police are separate than the healthcare worker, but that's not the case here. We do work as a team. Sometimes what happens is, and all police officers will tell you this, sometimes rapport building is different. Sometimes a rapport can be built by someone that you don't think will be able to build a rapport. So if the crisis worker is striking out, that other officer will engage, and so they work as a team to get information, and they don't work in separate silos, I guess is what I'm saying. Is the digital screener the size of a cell phone? It's about the size of a tablet, actually. So all our officers now have tablets in their cruisers, which are portable. So actually, they will take their portable tablet into a call with them, and they're actually doing the screener on this portable tablet, and it fits the screen perfectly. There's no issue there. And so as they're actually engaging with the person, they're actually noting the behavior down. By the time they get to the car, put the tablet back into the system and plug it back in, they can transmit right away. So, yeah, it's a very small little tablet, and it fits. It goes with the officer when they attend calls.
There's a question here. I mean, there's a lot of stuff coming in, so sorry, we probably won't be able to get to everything, but someone's asking, are victim services engaged in the crisis team, or are they engaged at any point?
No, our crisis workers come from New York Support Services Network, so that's where we draw from. That's our MOUs with them. So not to say that other services couldn't use victim services, but we really need a dedicated crisis worker with crisis training to be part of that team.
Okay, thank you. Let's see. So a question here, is mental health crisis training or trauma-informed practice training something that all officers in York Region undergo, even outside of your unit?
Yes, so we offer what we call crisis intervention training. So as an officer graduates through classifications, generally they'll go to OPC, which is the Ontario Police College. They'll come back. They'll go on the road for a year. They'll come back for a couple of weeks of training in between their second class to third class or first class to second class. So all our new officers are now being trained on CIT. So that means not only will the crisis workers go in, but our social workers go in, and Sergeant Palmer will go in, and our training branch will talk about, they'll bring in obviously different groups as to, whatever different afflictions that are out there, so they have some background. So yes, all our officers do receive crisis intervention training.
And I see some stuff has been addressed by some of our other participants. Thank you for that. Let's see what else we have. Someone was asking about how you know what the thresholds are for the situation table. Can you speak to that?
Yeah, and I can, but I'm not the expert at it, because it's my social workers and Sergeant Palmer, but essentially there's got to be that acutely elevated risk threshold, which basically means there are a harm to themselves or others at some point. There's enough information that let's say it's a police report where we have spoken with the family, we've spoken with the person that's suffering, and that has given us what we believe. Now, it doesn't mean that other partners around the table can't opt out. If they don't believe that there is an acutely elevated risk here, they can opt out and not share information. That has happened on rare occasions where people have opted out because they don't believe the risk has been met. But that doesn't, again, it doesn't happen every day, and we have to respect that. Because if they don't, everyone's governed by different rules and regulations. The police are no different than that. So again, we will do our best, and we will respect everyone at the table, because without that respect, it's not going to work. So, and we don't want people to feel compelled just because the police service is presenting something that they have to agree with us. That's the last thing we want. That isn't any good for anybody, and that's why we respect the rules of the situation table.
Great. And so, yes, in response to this question, we'll make the presentation available, the slides as a PDF. We'll go on our website, and we'll also send out a direct email to all of our participants with the slides, the recording, and I can also include your email address if you would like.
Yeah, again, I'm sorry I couldn't get to every question. I didn't anticipate that, but again, thank you very much for hearing me out. And they said I'm not an expert by any means. I'm just a lowly police officer that has a passion for doing this. So thank you for for bearing with me as I stumbled through my presentation.
It was a wonderful presentation. Thank you so much for joining us today, and thanks again to everyone for participating. We had lots of engagement today. It's great to see such an amazing turnout for this. So I think that's everything for today. Thanks again, and have a great afternoon, everyone. Hi, folks. So if you are